Hello everyone. Welcome to our final lecture for Diversity in Medicine this quarter. Today we'll be discussing a new topic for the seminar, which is prison health disparities. Our speaker today, Dr. Mark Malek, is an adjunct associate professor in epidemiology at UCLA. He received his MPH at Johns Hopkins University and his MD from UCLA. He is currently the Director of Infection Control and Epidemiology and Employee Health Units for the LA County Sheriff's Department jail system. One aspect of his current research is the establishment of surveillance, research, and programs to prevent the spread of communicable diseases, transmission, screening, and prevention interventions within the Los Angeles County Jail. Without further ado, please give a warm welcome to Dr. Mark Malek.
Thank you, guys. Thank you for the very nice introduction. And thanks for coming, because I know you guys, I guess you have finals. Wait, next week's 10th week, right? So it's good that you showed up. Thank you. But one thing that I didn't provide to Neha was maybe the most relevant thing is I'm an anteater too. So I went to college here. Yeah, we didn't have that when I went to school here though. So what I wanted to talk to you guys about today, instead of just giving you some raw data about corrections or correctional health disparities, I thought it's a little more interesting if I bring together some of the important issues and expand the discussion a little bit further. So you can just say, well, we incarcerate a lot more minorities in this country. We incarcerate more people than any other country in the world. But it's more interesting and more informative to look at how that plays together in people's health. And I thought one of the most important public health ways that we can look at this is the issues that really affect this population. A population that often is thought of as being behind bars, out of sight, out of mind. But really, if you look at the data, and it's all in the numbers, people are going to go to jail, they're going to come right back out. They're going to come back to the communities where they came from. Over 90% of people in state prison, for example, in California, are going to be back in their home communities within 2 years. So we can think of this population as one that's out of sight, out of mind, that we don't want to provide health care to, or we can think of them as an opportunity. So when we get people and they're clustered together, we get our chance to provide them with health care, with screening, and to capture them when otherwise we may not be able to capture them. So this is, so I don't know if you can see it so well. There's a lot of light right there. I'm afraid to mess with the lights because I think I've heard that there's an issue with lighting in this lecture hall. So
it has a mind of its own.
Yeah. So if something happens with the lights, we'll roll with it. Okay, you guys? Is that cool? So this, if you can read it, it says it is a felony to engage in sexual activity within the Los Angeles County Jail. Okay? So that's a state law. Penal code, blah, 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 whatever. Underneath that is the condom drop box. So this is actually in our gay and transgender dorms. That's a place where the sheriff does allow distribution of condoms. But what I put this here because it illustrates the paradox. So law enforcement agency, sheriff's department, they are charged with doing what? Enforcing the law, right? And that's the law right there. But at the same time, it's an extremely high risk infectious disease population, and guess what? People do have sex in jail. So are we going to allow outbreaks of syphilis, gonorrhea, chlamydia, and other sexually transmitted diseases occur in jail? Well, that's why we have the condoms. So we have the condoms because we know that we need to have them, but at the same time, the sheriff's department technically can't be condoning sexual activity, which is a felony. So working in this environment is intrinsically difficult, so to speak. Yeah, there's a question.
So
Why is it locked? Well, there's no reason. Well, for one thing, they want to be able to count. So in jail, everything has to be counted. They want to know, the deputies want to know how many of whatever were given out and how many were collected so they know how many are left. If there's a big discrepancy, for example, something like condoms could be used as currency. There's not money floating around in the jail, but something like that, for example, could be used as a currency. And they want to be able to know, also to track the use of the condoms to know how many people are really using them or not. so we know our program's effective. But the short answer, everything's locked in jail. So if there's something in there, there's going to be a lock on it. Briefly, what I'll talk about is, for those of you who may not be familiar with corrections, and I use that term as a noun, I use it broadly to cover jail and prisons. I'll tell you the difference between the two. Since I work at LA County and since it's the largest jail in the United States, I will give a little bit of an overview of the LA County Jail. And then to frame the context of this discussion, I'll talk about some common public health issues. So, to me, since I do this every day, I know what diseases I'm thinking about or what diseases this population has, but you guys might not. A lot of people don't. And then since, I was a biology undergrad, and probably a lot of you guys are too, I think it's interesting to talk about some of the biology and the relationship between infectious diseases, that's what ID is, sorry for the abbreviation, and drug abuse. And then if we have time, get into some of the ethical reasons of treating drug abuse in jails and prisons. So what's jail, what's prison? When you see on TV, a lot of times you hear the terms used interchangeably. They're actually completely different. So jail in the United States is a county or local facility, okay? You will often see the jail facility near downtown of a county. Why is that? Anybody have any thoughts? I don't want you guys to fall asleep. I don't mean to pick on anyone, but I just want you guys to be thinking a little bit. Okay, I won't pick on anyone. Thank you. Brave. Exactly, yeah. So I don't ask tough questions. And you guys, if you have questions, by the way, feel free to ask, or if you have comments or something. But exactly like you said, and thank you for helping me out. So jails are near the courthouses because a jail is a place where you will be going to court. For example, if someone may be sentenced, they'll be going to and from court. So, those people have to be moved on buses. LA County, for example, Sheriff's Department. Our Sheriff's Department has the 6th largest bus system in the United States. That's after, New York, Miami, Chicago, the city of Los Angeles. I mean, just comparing all other municipalities. Because the inmates have to be moved to and from court. They have to be bused to state prisons once they get sentenced. So prison is where inmates will serve their time if they're sentenced to a felony conviction, and it's usually 2 years or more. Whereas jail is short stay or less than a year, sentences that are less than 1 year. Okay, and then the prison system, there's either state or federal, depending on the type of crime. I'm not a criminology expert, so I'm not going to pretend like I am, but those are some of the basics. So one thing that's really fascinating, mass incarceration. So I mentioned a little bit earlier that the United States incarcerates more than any other country in the world. The rate of incarceration is much higher than any other country in the world. If you put all 35 industrialized countries in Europe together, the number of persons they incarcerate is still lower than the number the United States incarcerates. Okay, so in 1970, I investigate outbreaks. So I have to think in terms of outbreaks and trends and that type of thing. So in 1970, we had 250,000 individuals incarcerated in this country. And then in 2008 or 2009, we had approximately 2.5 million. So that's a couple more zeros there. So why did that happen? You guys have any thoughts? Did we become a worse society? Did we become worse people? And so we had to incarcerate more? Yeah, another brave soul.
It's political. Like, it's the politics of things. Like, the whole entire talk on crime.
Uh-huh.
And, like, how, like, legislation, like, any legislator will say they're tough on crime. It's also because of businesses. Because if they have more prisoners, you'll be able to have more people to work for unfair wages in prison, too.
Exactly. So she brings up a lot of the important points. And maybe not everyone can hear her, but politics and economics and the law. So in the 70s and the 80s, what happened, we started incarcerating more because of drugs. And that before, actually, when you look at the same period, if you look at a graph, you'll see that property and violent crimes actually went down during the same period when the total number of incarcerations went up. And that's because we made new laws. So we're incarcerating because of drug convictions, and also mental health, dismantling of the mental health complex. So we're starting to put a lot more people now over these 2-3 decades who have drug problems and mental health problems. When you look at the numbers also in the third bullet, more than 10 million people are booked in jails annually. So we're not talking about a small number. I mean, you talk about 2.5 million incarcerated, that's at any given time. But when you talk about how many people go through what we call the revolving door, that's now it's about 8 to 10 million. But as of a few years ago, it was about 10 million. And when you look at how many people are affected by this, it's more than 30 million Americans. So if somebody goes to jail, their family is affected by it. If they have kids, if they have spouses, if they have grandparents that they may support, or who may be looking for them to help take care of them when they get older. So you have to look at it from a societal perspective, not just that individual. Who is primarily affected? Young minority males, and they make up 3% of the population by ethnicity, race, ethnicity, and age, if you look at that demographic, and yet they're the ones who make up the majority of the jail and prison population. Specifically, poor neighborhoods in urban areas, and more than some communities have more than 90% of families that are affected by incarceration. So just think about that. Yeah.
So I don't remember what the U.S. population was in 1970, but was the proportion of U.S. population in jails in 1970 also young minority 3%, or has that changed over?
It has changed. I don't know exactly how much it's changed, but your question, it's a good question, because basically what he's asking, if you couldn't hear him, he's asking about, well, a couple things, looking at rates for one thing, and not just the numbers, but also looking at the proportion of the population. So yes, it's changed. 3% is as of about 2008. I don't know exactly what it was, to be honest with you, in 1970. It may have been a lot or little. I'm not really sure. Sorry.
No, it's okay. But
yeah, but you raise a good point, though.
Yeah, the minority. So because it's drugs related,
right,
conviction, very likely minorities are disproportionately affected by the growth than it was in 1970.
Oh, I see what you're saying. Yeah. That's probably very true. I'm not sure. So, again, if I'm looking at this from a public health point of view, such as investigating an outbreak, or looking at a problem, one of the things you want to know is how big of a problem is it. So if you look, for example, at drug abuse, which comprises most of the incarcerations, we'd say in that period there were 7 million drug incarcerations. In public health, we like to look at something called years of life lost. So if someone dies of a disease prematurely, how many productive years of life were lost? And in this case, if you calculate it, it's about 14 million years of life lost. To give you a perspective, that's more than 350,000 deaths in similar age population during World War II. So you're talking about taking the young, most productive members of the society, particularly from urban neighborhoods, impoverished neighborhoods, minority neighborhoods, and you're basically taking them out of society. So what are the effects of what's termed mass? I didn't come up with these terms, mass incarceration, by the way. If you're interested in reading more, a lot of these data come from a book by Drucker, and it's called The Plague of Prisons. He does a really good job of portraying incarceration actually as an infectious disease, communicable disease, I should say, not infectious. So just to think of who we're talking about, to frame the discussion, we're talking about socially marginalized people, and the effect of incarceration is lifelong. It's not just for the 2 weeks that you get incarcerated. I have met numerous inmates who have been incarcerated and as a result, for example, lost their apartments. They were evicted because they were incarcerated, they didn't pay the rent, and they were booted from their apartment, for example. Recidivism is high. So recidivism means they're just coming back. They get arrested, they get released, and they come back. Is this surprising if we're thinking about substance abusers, for example, many of whom are trying to quit their habit and they can't? and they're going to get rearrested for the same substance abuse problems or parole violations a lot of times. Stigma. So how many people, employers, for example, I mean, we hear about veterans of the military, for example, having a hard time getting jobs when they come back. So imagine how difficult it is for someone who's incarcerated when that shows up on their resume or on the questionnaire that they fill out, right? So unemployment's difficult. Without employment, how are you supposed to find a place to live? What's fascinating is the voting rights. So in some localities in the United States, African Americans, more than 40% of them cannot vote because they've been incarcerated. So when you compare that to other countries, incarcerated persons are mandated to vote. So we have a different philosophy in this country, not just about incarceration, but about things associated with incarceration. And the disruption of family life, when their dad or their mom is incarcerated and the kids don't have their parent around. In fact, kids whose parents are incarcerated are controlling for things like socioeconomic status, education. Kids whose parents were incarcerated, either one, are 6 to 7 times more likely to be incarcerated themselves. So you can start to see why it makes sense to think of this as a communicable disease, as something that can generate more people who are incarcerated. Not just the individual coming back, but their children also. So, like I said, if you think of a communicable disease, it has to be propagated, right? Without going into things like R0 and you have to think of people who are susceptible and people who have the condition, right? So because the kids can be incarcerated because they're affected by their parents' incarceration, they have instability in their lives, right? Also, what's paradoxical is that neighborhoods that have higher incarceration rates have increased crime. And you'd say, well, yeah, of course, I mean, there's crime, so they get arrested. No, actually, what happens is the crime comes after the incarceration. So it's not like you're having a lot of crime, so the police go in and start arresting people, and so they go to jail. No, it's the opposite. So it's actually a cause rather than an effect. And also, as someone brought up earlier, it's a very lucrative business. So if you have an industry where you have 1-to-1 employee to inmate ratio, there's incentive for people to incarcerate. When the economy was doing well in the 80s and states had surpluses in their budgets, of course there was an incentive to build more jails. They say, we're making jobs, right? But all of a sudden when the economy wasn't doing so well later on, now you don't hear about people wanting to build jails and prisons. Now the trend is the opposite. We're releasing prisoners. We're sending people from state prison back to the local county jails. And also, a very powerful lobby in California especially is the prisoner guard lobby. So a lot of economic interests. Yeah, question?
Can you comment on why the neighborhoods have more crime when there's a higher rate of incarceration?
Yeah, so she's asking about if you incarcerate a bunch of people and then there's more crime after. So these are just theories that I've heard other people propose, but it kind of makes sense. Basically, if you're incarcerating people and they can't hold stable jobs and there's instability at home, there's instability paying the rent, those areas tend to have more people turn to more crime. Organized crime was another theory, is that in those places, sometimes people go in for one charge, they go into jail and they learn other crimes and they come out and they're propagating other crimes and then they recruit family members or other people. And so, a lot of different individuals in a single family can end up going into crime and getting incarcerated, and it leads to more instability. So instead of thinking about how we could use our tax dollars, for example, to what we call diversion programs. So if there are people who don't have job skills, who don't have communication skills, who have drug abuse problems, instead of spending money on trying to treat those problems and help these people stand on their feet, we build more cells, we build more jails. California especially, we think we're progressive here in California. when you look at our laws about incarceration, we're actually really tough on incarceration. You know, recently we finally just repealed the 3 strikes law, some conditions of the 3 strikes law. For example, job training, education. I deal with a lot of patients on Skid Row. I have an HIV clinic where I work with USC on Skid Row, and I see a lot of the same inmates inside the jail, and then I see these people when they get back out on the street. And the level of functioning of a lot of these people is just, they can't function independently. They need help. We need to put their medications in their pill boxes for them, otherwise they wouldn't, you can't go to Kaiser or wherever else and expect that someone's going to put your pill box together for you, right? But these patients, if we don't, they're not going to take their HIV medications. Filling out paperwork. They don't have addresses, for example. So a lot of this type of stuff, these, how much more difficult is it for one of these people to get a steady job? They need some hand-holding. And I'm not going to go into the reasons of society or who did it or whose fault or accountability, but the bottom line is that's where these people are. And without training and assistance and education, they're not going to get out of that. And we're just going to keep paying our tax dollars to reincarcerate them and cause more public, a lack of public safety in the process. So the political issues, again, that were brought up. So there's a fear factor about criminals. They're criminals, they're bad. We've voted in harsher, longer sentencing policies, especially here in California. And like I said earlier, more than 90% of prisoners will return back to their communities. So we're not getting rid of them. They're going to come back. We have to deal with them one way or the other. So looking specifically at substance abuse treatment. And I say substance abuse because when you look at these numbers, you kind of understand it's almost the correctional population and the substance abuse problem, it's almost the same exact population. It's very much synonymous. So 70 to 85% of U.S. prisoners need drug abuse treatment. Okay? And when you look at, for example, our data at LA County Jail, we know it's about 60 to 70% are there for charges related to substance abuse. When you add property crimes, maybe they were stealing to get drugs, maybe they were having illegal sex or selling sex or selling drugs basically to get drugs, then you understand it's really probably much higher than this, but we can only estimate that proportion. And really only a very, very small minority, very, very small portion of the population in prison receives substance abuse treatment. So 15 to 20% of prisoners. When I say 15 to 20%, that's based on data that there was at least one service offered. So when you look at true substance abuse treatment, there's counseling, there's medication, there's support groups, there's a variety of things. So just throwing one thing at a person is not going to be the magic bullet to get them off of drugs. Communicable disease risk is elevated for a variety of reasons that I'll go into a little bit later. And add to that the mental health problems. So you have people who have mental health problems. Are they using drugs to self-medicate? Yeah, some of them. Did some of them cause or accelerate the onset of some of their mental health problems by using drugs? Yeah, so it's kind of both ways. Very, very high co-occurring disorders between mental health and substance abuse. And with that, infectious diseases. You can't separate those three. They're so closely interrelated. Does anyone know what the number one risk factor for HIV in the US is right now? HIV acquisition? Number one risk factor. It's meth. So meth causes people to be hypersexual. They go on binges. They have meth parties, and they may have multiple sexual partners. And that's the number one risk factor right now for HIV in the US. So that gives you kind of an example. Also, solitary confinement. It's very interesting, the effects of solitary confinement. We have 50% of the incarcerated population who's in solitary confinement, and yet we have 5% of the world's population. And there are reams of data and reports that you can look at of the effects of solitary confinement. We'll go briefly talk a little bit about LA County Jail, since it's up the freeway. These are just some pictures taken from the Inmate Reception Center. So this is where any inmate who's booked and processed to the LA County Jail is going to be processed. Sorry, these guys in the upper left corner, they're being searched for any additional contraband. You can see they're still wearing their plain clothes, and various different parts of the medical services. You can see some pictures there. Bottom left corner, those are patients who have rule out TB, tuberculosis patients. You can imagine in a jail when you crowd a bunch of people together, they're higher risk for respiratory and airborne diseases like tuberculosis. So we have to have a way of screening people, otherwise we could have an outbreak in the jail. Anybody follow the news and hear about the outbreak, the TB outbreak among the homeless in Los Angeles? So how many of those homeless people end up getting incarcerated? A lot of them. So, you know, these issues that you think about, infectious disease does not necessarily pay attention to the walls of the jail. And we have to be careful. There was a county jail that was shut down for 2 weeks, and the courts in that county, because of one small outbreak of tuberculosis in the jail, for example. And that's just a picture of one of our doctors doing an exam in the inmate reception center. So in order to understand a little bit about corrections and about incarceration, I think it's good to understand the structure of the sheriff's department, because they're the guys who administer the jail. There's custody personnel, so all these guys have badges. They don't have guns in the jail. Guns are not brought into the jail. They have flashlights, they have batons, maybe. They have more weapons that are used for non-lethal force. So they might have tasers, that kind of thing. And some of those guys have the keys to the cells, whereas a whole other group, and probably the majority of them, are the people who run the jail like a city. So if you're in the jail, somebody has to do your laundry. You have to have a doctor because you can't get up and go to your doctor on the outside, right? The food services, all these different services have to be provided. Los Angeles County Jail is technically the largest sheriff's department and the largest jail in the world. We incarcerate about 17 and a half, really now these days, 18 to 20,000 inmates. And that's over 8 or 9 facilities, sometimes some are temporarily closed, spread all over the county. There's a women's facility in Linwood, and then some facilities downtown, and then another few facilities north near Magic Mountain. So look at these numbers. Usually when I talk about 13 to 17,000 bookings and releases monthly, most other municipal jails don't even reach that in a year. I'm not saying that with pride, because it's nothing to be proud of, but it's just the sheer numbers of what we're dealing with. And this is not a very healthy population. More than half of them are on what we call pill call. So that means 3 times a day there's a nurse who comes around with a cart with medications in a sealed plastic bag, and it has their name, the name of the medication, the route, the dosage, and the frequency, and the medications are given to the inmates on a daily basis. Some they're allowed to take what we call self-meds. So they'll take 14-day supply, for example, and then they'll take the meds on their own, just like you would if you go to your doctor and you take the drugs home. That's a picture of the Twin Towers. In the foreground, the picture on the left, there's 2 towers. The one that you see, it has larger windows up top, if you can see it on the left all the way. That's Tower 1. That's technically the largest mental health facility in the United States. More than 2,000 individuals. That's where the individuals with mental health problems will be incarcerated. And then the farther is Tower 2, which is primarily violent criminals. And then across the street, you see the concrete thing that's about 4 or 5 stories high. That's Men's Central Jail. That was built in the 50s. And that houses a huge mixed bag of different inmates. This is a really old picture, by the way. It looks different now, but. So what do these people look like? Surprise, surprise. Most of them are male, 88%. About half are Hispanic. So that mirrors the population of LA County, right? It's about 50% Hispanic. The African American or black population is way overrepresented. And then about at 35%, 12% Caucasian, and 3% is a mixed bag of others. So how long do these people stay? So again, to make the point, people think, well, they're in jail, so they're going to be there for a while. So anybody who studies statistics, you have to look at this in a couple ways. One, the mean or average length of stay is 44 days. So we have some people who stay for years or months, but that's the minority. Most of the people are there like any other county jail in the US. They're going to be there for 10 to 20 days. You've even got a group of people who are going to be there for 24 to 48 hours. They'll walk in the door, get processed, and then they'll be out the next day within a day or two. So where do these people go when they're released? Most of them, 75%, go back to their communities. Sorry, that should say communities overall. About a quarter go to state prison, and then 1% or less are deported back to other countries. So what kind of medical services do we provide? Medical and dental services. During screening, there are multiple different medical screenings that inmates go through when they come in the inmate reception center. We have outpatient clinics, we have urgent care clinics, we have ophthalmologists, orthopedic surgeon, physical therapy. We give pretty good health care. And a lot of indicators in the data indicate that, when people are incarcerated, they get good health care. When they get out, then that's a different story. A lot of times we see that their different indicators of their health status decline. Some inmates, and if you look it up in the LA Times a few years ago, there was an article arguing that if inmates were incarcerated at home, or if they were on different, wearing ankle bracelets and that sort of thing, that it would be unfair because they wouldn't have any place to get their medical care. So this is just a little brain break, because I know it's late. I don't know how you guys can even take a lecture this late. But these are some of the sort of notable, infamous inmates that we've had. OJ was a Trojan. I went to med school at UCLA, so I have to point that out. And that's her mugshot. That's Paris' actual mugshot. And these are, Lindsay Lohan's 4 different mugshots. I got this from thedirt.com. So if you're interested and you'd like to vote on which mugshot you like, I'm not kidding. You can vote on which mugshot you like best. So what changed? Did we always give good health care in jails and prisons, you guys? Anybody have any thoughts? Yeah.
I would think no, because they're considered like the low life of society, so
Yeah.
why would we care about their health?
Yeah, so it's true. She said no. I don't think so. Society doesn't look highly upon the incarcerated population. So no. Basically, in the 70s, in 1976, there was, I think I talked about it, yeah. There was the Supreme Court made a decision on a case, and I'll tell you about that in a second. And that's really what changed everything. After that time, it's like before that time, healthcare, and then after that time, completely different. And what they said is, you have to give medical care. So can an inmate, like we said, does an inmate have Blue Cross or Kaiser? Can they get up and go see their doctor if they feel like it? No. There's something called a bar that they're behind, right? They can't just walk out. And because of this case, though, is very interesting actually and somewhat controversial. This became the first population, and for a while the only population, to have a constitutional right to medical care. Okay? Because what document does the Supreme Court interpret? What's their authority based on? U.S. Constitution. So what they decided in this case is that if you don't provide medical care, it's a violation of the 8th Amendment to the Constitution, which says you will not have cruel and unusual punishment. So that's cruel and unusual punishment. You're torturing someone, you're making them sick, and you're not giving them medical care. What do you guys think about that? I mean, on the one hand, okay, put on your idealistic hat and say, well, yeah, because they're locked behind bars. But on the other hand, how many of you people work? And does your, or how many people work at a job, for example, where they don't get health care? Why do you not, a lot of people, and you don't have to show your hands, but I know. Why do you work and not have access to health care, and yet someone who's incarcerated has access to health care because they are incarcerated? So I don't say that because obviously I think that they should, but I don't want to have just an idealistic consideration of the subject. I don't want you guys walking out here saying, oh yeah, they should all, and everything should be perfect. There's reality. There's a finite amount of money that we can throw at diseases and at medical care. And yeah, you have a comment in the back.
I actually have a question for you.
Sure.
It might be a little personal, but as a medical doctor,
Uh-huh.
you're held at a standard where you're supposed to provide every patient with equal treatment. But as a medical doctor, when you're in a jail or a prison and you're providing an inmate with a service or a treatment, or you're saving their life, when you're looking at them and you're saying, okay, this person was a mass murderer, someone who killed, how do you separate yourself from all of the society or how we usually view inmates as a low life and provide them with that ideal care that we're supposed to provide them? How do you just forget that they were a mass murderer? Especially since you took a vow to do no harm. So in a way you were saying, if I help this guy out who is going to kill more people, I'm kind of doing harm to my society. So how do you deal with that?
No, that's an excellent question. Somebody's awake. Thank you. No, I appreciate that you guys are thinking. And no, I'm not offended by anybody who falls asleep. I'm not teasing anyone. But no, I appreciate that you're thinking and you're being honest. Because that's what, if you're not thinking and being stimulated, then I'm not doing my job. So he's asking if you're treating someone who's committed a crime. So think of heinous crimes. I don't have to mention anything, but think of what's a heinous crime to you. And you have that patient in front of you. How are you going to treat him? Or how am I going to be, why do I want to advocate? Why do I want to say, yeah, we should have hepatitis B vaccines for these inmates because they're at high risk. Why do I care about that? Bless you. Well, a couple things. One is, yeah, I took an oath. And there's a huge responsibility that comes with being a physician. And with it, it's a huge privilege and it's also a huge responsibility. In the everyday kind of thing, when you see that person in front of you and you're like, how can I take care of this person? I never want to know what anyone did. Because if I do, whether I like it or not, how hard is it when you think of whatever heinous crime, how hard is it then to try and treat this patient? But I'll also throw another thing at you though too, is most of these inmates, and I deal with them day to day, and people say, oh, aren't you worried about violence or something, or they're going to hurt you? The inmates, you treat them with respect. They're still human beings. They treat you with respect. Most of the inmates that I've encountered, and I've encountered a lot, they have disorganized lives. They are not inherently evil people by any stretch. I've honestly, I can say this with a straight face, I have met some wonderful people who were inmates in the jail, and they just haven't had their life together, and it's been disorganized. That's been the majority. And most of the inmates, the very, very small amount are the truly violent people who we really do need to remove from society. But that you're talking about the 5 to 10%. And most of them, and I like to focus on the 90%, who do need the help, who when we help them, we save our own tax dollars, So, yeah, thank you for that. There's another question, you and then you.
Have you ever encountered a dangerous situation?
No, I've never had a dangerous situation. I've had the opposite. I've been, and I'll explain. So I may go in and talk to a dorm full of inmates and tell them, we're offering flu vaccines or hepatitis vaccines. I'm very passionate about vaccines. Don't listen to Jenny McCarthy. They do not cause autism, okay? And the guy who used a lot of that data, Tim Wakefield, fudged his data. It was a lie. So you can Google Tim Wakefield, look it up. Lancet printed a retraction in 2010. Sorry, digression. But when I'm giving a class sometimes, and there's one guy and he was writing with his pencil and his pencil broke and he yelled an expletive because his pencil broke. And a couple of the guys went up to him and they threatened him. They said, you better, because Dr. Malek's teaching us and this is for our health and this is helping us. And I was like, okay guys, chill. It's okay. He's having a bad day. His pencil broke. So no, I've never been in that situation. I've had nurses that I supervise too in public health that they've had inmates who have said, you know what, I saw you on the outside and my buddy wanted to jack your car and I recognized you and I told him not to. And the details of where he said she was on that day, he was right. He really did see her. He said, I saw you on the, on Crenshaw and whatever. And she was like, yeah, I was there. It's a little freaky, But he said, no, don't worry, because we know how much you take care of us, and I got, we got your back on the outside. So there's kind of a rule to things, and there's a respect, and there's a very strict code and a culture. And since we respect them and take care of them, no, never ever been threatened. Yeah, sorry, one over here.
I was wondering, when you say it's good healthcare, how do you think it's good healthcare? Because most of them are only in for 2 weeks. So these services you offer, and especially because some of them may have major problems, do you continue to offer them afterwards, or is it only for that 2-week period?
So good question. An excellent, actually very, very excellent, important issue that she brought up. She's asking, how can you say it's good healthcare if you have people for a couple weeks or a couple months in some cases, and then they get out? So we call this transitional care, right? Like they're transitioning to the community, and we're trying to reintegrate them into society. So no, we can do certain things to help them transition into society, but we have laboratory objective indicators. So for HIV patients, for example, we measure a certain type of white blood cell called T cells. And when the HIV virus kills the T cells, so when we treat someone, their T cell count goes up. They start, they're not getting killed by the virus. Uniformly from study to study, and every year it's getting a little bit better, people who are incarcerated with HIV have T cells that increase steadily. When they get out of jail, we have trouble keeping them coming back to the doctor. We have trouble keeping them on their medications. They may not continue to take their medications. So that retention into care, that's a big problem. So indicators like that are objective, that's how we can say, yeah, we know that these patients are doing better when they're in our care compared to when they're not. And that trend has been increasing. Yeah, another question.
So if you find someone with diabetes or HIV, how much medication do you give them?
So what do you mean how much? Like how many days supply, you mean? Okay, so when an inmate is released, we have transitional medication. So they'll get 7 days worth of medication. That's another one of these areas where it's not nearly enough for the person to get reestablished into medical care. We say innocent until proven guilty, right? But when they go into jail, they lose any kind of federal medical benefits that they had. So if they were on Medicaid or anything like that, they lose it. It usually takes about 30 days to get reestablished into care. So you get 7 days of meds, you have to try and figure out a way to get the rest of the medications that you need for that period. But it's, at the same time, the Sheriff's Department has its own budget. LA County Department of Health Services has its own budget. So how do you, it's the reality, the fiscal realities, come into play there. So I'm just going to keep going a little bit, sorry. 1976, so we were talking about the improvements in healthcare. So there, Estelle versus Gamble. And there was a case, and the inmate said, I have back pain, my back hurts. And they basically did what's called deliberate indifference. They ignored it. They said, no, you're fine. So it turned out it was a manifestation of a heart attack. It wasn't, he wasn't picking up too many, heavy things or whatever. So he ended up having a heart attack and died in custody. That's when this case went to the Supreme Court. They reviewed it and they said, you have to provide medical care to inmates. And that's what caused a huge difference in medical care. So now we're thinking about, why should we care about these guys? When you think about HIV-infected Americans, 25% will be incarcerated every year in the United States, okay? 33% of those with hepatitis C will be incarcerated, and I don't know if you guys are aware of the numbers, but HIV, we have about 1.2 million people infected with HIV in the US. 20 to 25% don't even know that they have HIV, which is why testing is so important, like in places like jails, where we want to test people and say, hey, you have HIV. You got to take care of yourself, but you also have to not get other people sick, right? But there's about at least 4, maybe 5 million people with hepatitis C. So, that's another thing we have to think about in the future. Those are the people that we're going to be taking care of with our tax dollars taking care of a lot of these patients with hepatitis C. And when you look at tuberculosis, 40% of people who have active tuberculosis will be incarcerated. All of these percentages I'm talking about every single year. So when I think of this, not just is there a law that says, you know, the Supreme Court says we have to give medical care, I'm thinking of it as an opportunity. If these people are running around exposing other people to what they have, maybe we have a chance to finally get them. Do you think this population goes to their doctor regularly for their checkups? Right? So when we get them in jail, that's the time that we have an opportunity to test them and to get them into care. Also, you cannot consider, again, you know, you can't consider this population without thinking about mental disorders and alcohol and substance abuse. So axis 1 or 2, sorry, I'm used to talking to medical groups, so I apologize. Axis 1 or 2 means things like severe depression, schizophrenia. Axis 2 is like your personality disorders. So you're talking about people with severe mental pathology when you talk about, we're not talking about people who, you know, have minor mental health. So basically, this is the World Health Organization says it has now become clear that any national strategy for controlling infectious diseases require developing and including prison policies. It's not just here in the US, it's everywhere around the world. People realize this is a high-risk group of people. If we want to control spread of communicable diseases, we got to include these people, whether we like it or not, right? Whether we think they deserve health care or not. There's an economic and a societal benefit to treating these people and identifying them. So, like I said, opportunities. You take a lot of people that have substance abuse, that shoot needles, and whatever's in the blood, they're sharing with each other, that may have unprotected, high-risk, illicit sex, or maybe sex workers, right? So we get a chance to identify these people, to prevent transmission, and to offer them treatment that now is going to help keep them from getting other people sick. Have anybody hear of the term treatment, HIV treatment as prevention? So if I put, good, I'm glad because a lot of people don't hear that. If I put a patient on HIV antiretrovirals, you know, at least 3-drug combination, blah, 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 and I control their virus so that it's not detectable in their blood. It's still in their DNA, right? But it's not in their blood. Then the chance of them infecting other people goes down by more than 97%. So is that now a societal benefit? Am I not having that person preventing them from infecting other people? Of course it is. And what I've noticed is that it's an opportunity for teaching. If we go into a big housing unit and we say, hey, it's time for your hepatitis vaccine, and then, well, what's that? And why should I get that? If someone's on drugs, when we have them in jail, they're not on drugs. We have some really cool dogs that sniff out drugs and alcohol, and they find all kinds of stuff. There's just not as much access to drugs in jail or prison. They're not in their gang. They're at a time where they're like, well, you know what, maybe I should do something. You know, maybe it's enough. I got in jail again. It's not a happy place. Maybe I need to change my life. This is our chance when they're in there. And so a lot of times we are able to have a very frank dialogue at a point in their life when they want to make the change. Of course, it's a lot more complicated than that. But at least the person has to say, yeah, I want to stop drugs, or I don't want to do this crime, or whatever it is, fill in the blank. So, yeah, question. Sorry, I didn't see.
Has the pre-exposure profile been studied for the population?
No, so she's talking about PrEP, pre-exposure. So it's having a daily pill for certain high-risk subpopulations to prevent infection of HIV. And so no, we haven't been able to quantify yet how effective that is. That's another controversy.
Would it be even possible to run a study with that?
To be honest with you, that would be really tough because to do that, I don't mention it so much, but it's kind of inherently, it's kind of mentioned. The county jail, the sheriff's department, is a very, very highly litigated target. So what we'd have to do is do a study to say, here's the transmission that occurred in jail, and here's how many were prevented by PrEP. And by doing that, we are producing data that people can now sue, an organization over. So I don't know that that'll that'll ever happen. So a little bit about the biology of drug abuse. So what does it have to do with infectious diseases? Well, basically, drug abusers are more susceptible to infections all over the body, a variety of different areas of the body. A lot of different pathogens. I mean, we could spend hours talking about it. I won't, I promise you. Some of the ones we think of more commonly are, of course, HIV, hepatitis B and hepatitis C. And actually just the drugs themselves kind of modulate our immune system. They decrease our ability to fight against infections. So when you throw, maybe a person's homeless, they're not healthy because they're doing drugs or they're doing alcohol, and then you put an infectious disease in there, their immune system's not working so well. It's perfect for so many of these patients. When I see them, I look at them, and we have this term in medicine that we use, it's like older than stated age, and it's like, man, you look at someone and they're in their 40s or their 30s, and you for sure you'd think they're in their late 50s or something. It just takes a toll. Their body's been through a lot. Common drugs, like I need to mention this, but these are some of the common drugs that are used that we see in the jail. And what's the relationship between the transmission? So, like I said, the meth, the correlation between meth and high-risk sexual practices. If someone, and you don't have to think about meth, think about alcohol, okay? If someone's drunk, are they going to be thinking about who they're going to be having sex with or being careful or where's your condom or that kind of thing? No, right? So if something's impairing your function up here, you're probably not going to make the best decisions. A lot of substance abusers are in overcrowded housing. Are there places that commonly, market to rent to substance abusers? No. When you think of the early parts of the HIV epidemic in the early 80s, there were abandoned buildings in different boroughs in New York, especially Brooklyn, and there were people that were moving in there, and they had what was called shooting galleries, and they would share needles because it was you couldn't get needles, you couldn't get clean needles, there weren't needle exchange sites. So these people were sharing needles, and by doing that and passing it down, guess what else they were passing down? HIV. So in the very beginning, that's how HIV actually started to increase. Very neatly mapped process in Brooklyn in the early 80s. A very interesting point about that too is that our policy in limiting the number of needles, no, we can't let people have needles, they can't be doing drugs. Well, that's what actually led to a lot of these people having HIV in the early 80s. Malnutrition, if you volunteered at a hospital or if you've seen someone who's on a binge, they sometimes think that they have to have the drugs or they're going to die. They really, if you're in their head, they'll tell you, no, I really believe that if I didn't get that drug, if I didn't get my hit, I'm really going to die. So they can become violent. They can, they'll do whatever they need to get those drugs. Of course, they get incarcerated and drug contamination. Do you think that meth or E that you get on the street is 100% certified pure meth? There's all kinds of junk in there, including talc, and including, the list of things is amazing. Black tar heroin, it's actually, they've found shoe polish in black tar heroin. That doesn't go in your nose, that goes into your veins. So people have shot shoe polish into their veins. These are all documented outbreaks. Skin contaminants causing botulism, which can kill you, can paralyze you. And tetanus, different cutting agents because they want to cut costs, right? They're a business, so they put other things in there and there have been outbreaks of various skin and soft tissue infections, all kinds of stuff. And people shoot this into their veins, they put it into their central nervous systems. When you really think about it, it's amazing. The first, sorry for the abbreviations again, that's MRSA is staph infections, methicillin-resistant staph. The first outbreak was detected among a group of drug users in Detroit. It's even been an inhaled disease, which caused a terrible pneumonia. When I was in residency, I saw the first 2 patients who had staph pneumonia in 2004, and both of those young women lost one or both of their legs as a result. It's really early that physicians didn't know how to treat it yet. Bloodborne infections, right? And that's not just the needles. So people who share a meth or a crack pipe, and if there's burning and they have any blood and they share it, they can be transmitting probably more likely hepatitis B, than HIV. But who wants to have liver failure and liver cancer? And by the way, you guys, just kind of an interesting side note, we don't know exactly why, but Asian Pacific Islanders are much more likely to get chronic infection from hepatitis B, and they are much more likely to have it, so higher prevalence, and they're much more likely to progress to liver failure, cirrhosis, and liver cancer. In one outbreak, it's interesting, there was even malaria, so a tropical disease. We had one guy who had a staph, had a big boil on his back in the jail, and asked his cellmate to pop it for him because it was painful, and he popped it with a needle. So the guy who had it he was a homie from the hood. He'd been in the jail for like 9 months, and he ended up getting cutaneous leishmaniasis, which is a tropical disease, because his cellmate was from Central America and had a needle, and I guess he must have had it, and so he infected the buddy. So it's not a drug shooting needle, but it's the same principle. So what does this have to do, and how does this affect us in other ways? So for example, tuberculosis prevalence is increased among drug users. They're crowded in certain areas. Their immune systems aren't working so well. Are they worried about hygiene and not, spreading bugs to each other? Much higher HIV prevalence. And we've seen a lot. One outbreak that I thought was really interesting, unfortunate but interesting, these things called hotboxing and shotgunning. So like they'll go into the car and they'll get their weed and they'll smoke their weed, and then they want to inhale the secondhand smoke. So there have been outbreaks of TB because of that. TB is airborne, so you don't have to, it's not like a cold where you have to have close contact. It can be floating around in the room, let alone a car where people are sitting in there for a couple hours smoking weed together. Or shotgunning. There was an exotic dancer outbreak because of this. That was a colleague of mine investigated at CDC. And then if these people don't have good health care and they're busy, doing whatever they're going to do on the streets, do they go to the doctor? No. So by the time they may go to the doctor, or partially using their antibiotics, we see a lot of antibiotic drug resistance in this population. Do those antibiotics resistant drugs just stay in that population, or do they spread? Anybody hear of a disease called SARS? I got to the branch I worked in at CDC they were finishing up the investigation when I started working there. And literally there was one doctor in a hotel in China, and some people across the hall got the SARS, and those people went back to Toronto, and that's what caused the whole outbreak in Toronto, including in hospitals. So people were going to a hospital to get better for something completely unrelated, and they ended up getting SARS. Very clearly now we know that a plane ride can take in a bug anywhere around the world. So HIV, this is fascinating. So drug use accounts for at least 10% of HIV infections worldwide. That's probably a conservative estimate. We always think of it as being a sexually transmitted disease. So these guys, Strathdy and Stockman, they think it's closer to 40%, 40. So it's just, and then one question is discordant couples. So like when one spouse has HIV and the other one doesn't, a lot of times, some of those cases, they don't really know that it was from sexual transmission or if it was from drug abuse. Or sharing needles, sharing drug paraphernalia, basically. So hepatitis C, the prevalence is 40 to 90%. So now this should really get kind of the bells going off in your head. If we have hepatitis C, 4 million people or so in the US, and it's transmitted by IV drug abuse, where do we find a lot of these IV drug abusers other than needle exchange clinics? We find them in jail. So this is a huge opportunity. This is also a huge challenge. We now have drugs that are oral for hepatitis C. We can cure hepatitis C at rates of 90% or more with these new drugs. I mean, these are just coming out. FDA is just approving them, a couple last year, a couple more this year and next year. But it costs $40,000 per course. So what are we going to do? I mean, to put it in the words of the New York State Commissioner of Prisons, he said, if I if I treated all my patients for hepatitis C, this is even before we had these new cooler treatments that actually have high success rates. Before it was like 30, 40%. Then he said, I would bankrupt my complete budget would be used just for treating hepatitis C patients. Forget all the diabetes, high blood pressure, you name it, every other disease, non-communicable even. So, what are we going to do? And then how are we going to keep this? If a person gets treated now and then they go back to using their IV drugs again, they're going to get reinfected again. So a huge challenge. This is also kind of near and dear to my heart because my parents came from Egypt in the 60s, and Egypt actually has the highest rate of Hep C of any country in the world. It's called one of the worst public health disasters because they had a treatment campaign for a tropical disease called schistosomiasis, and they were bringing people back at 6-month intervals, and the idea of infection control and using needles was not known at that point, so they think that they were using the contaminated needles, and it actually caused infection of about 20% of the population of Egypt. So what's the public health impact? When you look at kind of all these things, I don't have to go everything in detail, but a lot of STDs. With STDs, anybody who has an STD is at higher risk for acquiring or transmitting HIV too, because there's inflammation in the genital area. Up to 60% of IV drug abusers had a past history of a sexually transmitted disease. The technical term now is sexually transmitted infection, but whatever, you know what I'm talking about. And this includes non-injection drug abusers. So like meth, for example, we talked about that. They're also selling sex for money or for drugs, for drugs or the money to get the drugs. Just so intrinsically enmeshed, these issues. I mean, for so many different reasons. And a fascinating thing is a network analysis of some of the sex workers. They were found to have some specific strains. So you've got a network of drug users here. You've got a network maybe of sex workers over here. And 1 or 2 people may cause a link to that other network. And now you have this newly evolved strain that may be resistant to antibiotics, and it gets spread over here to this other group. So the effects clearly go beyond just the drug users. So we kind of said earlier that it affects the immune system. So in a lot of different ways. Cocaine, for example, is a very well-known one, that it actually increases the viral load of HIV. So the amount of virus that's floating around in your blood if you're HIV infected, it actually goes up just from using cocaine. It also decreases your CD4, or your T cell count. So the T cell counts are the ones that are in charge of the whole immune system. So you're knocking out some of the T cells, and you're increasing the HIV viral load. It's like cocaine, you're trying to take cocaine to make your HIV infection worse, if you kind of think of it that way, in a warped kind of way. So specifically in some of the neurobiologic pathways, it's very interesting when you look at how substance abuse affects the neurobiologic pathways in the brain. It fundamentally changes reward and motivation, learning and memory. This is permanently. So you're talking about the way, so imagine I'm used to taking a needle and having a high from it, and my dopamine goes crazy in my brain, right, within a few seconds. So now, if you tell me that I'm going to have delayed gratification of going to school, and then how many people are going to go to graduate school or medical school, or planning on it, right? You guys are all going to go. If I made it, you can make it too, right? So how does that affect, if I'm used to getting a reward in like 5 or 10 seconds, and you tell me, yeah, you go to school, that's not even on my radar. There's no way I'm going to be thinking about tomorrow, let alone how to improve my life and my career and, do something, right? These are permanent. I'm no substance abuse expert, but I deal with it so much that it just leaves an impression on you. And you just see this stuff and you're like, yeah. When I read about it in the literature and the research, I'm like, yeah, I see this every day. I know exactly what you're talking about. Cognitive control of emotions and inhibitions. So let's say someone's on drugs. Now they don't control their thoughts or their actions. Do you think that's going to make them more likely to get landed in jail? Right? You think maybe when a cop just talks to them like, hey, how are you? That they're going to do something unpredictable, and then maybe end up causing harm to themselves, and then later on realizing, oh, I didn't even mean to do that. I thought you were after, just misunderstanding of what the cop was really talking to them about. I've heard many stories about that. Even awareness of body signals, knowing when you're thirsty or hungry, when you need to pee, just basic stuff. It fundamentally affects a lot of these things in your body. So when you think about these things, I mean, I've met homeless people who've been arrested because of public indecency. There's a bathroom right next door to them right there. And I'm like, why didn't you just go to the bathroom? And he got arrested because the cops saw him urinating in public. And he was like, I didn't know I had to go. And all of a sudden I had to go, and I didn't want to wet my pants because it was cold and that was the only pair of pants I had. Just things like this. Making adaptive decisions. So all these things, when you really understand these things, then you start to go, oh, now I can see why some of these people don't have their lives together. So instead of saying, yeah, that person's evil and they're bad and let's put them behind bars, I can understand, I can have compassion towards this person now instead of having extreme, fear or hatred or whatever it might be. Reincarceration rates. Look at like impulsive decision making. You get the point. There's a lot of detail here. I don't have to belabor it. But they do the drugs, they get out, they're off of it, especially when you go in. So what happens to your urge when you go into jail and you don't have access to drugs? The longer you stay off of the drugs, the more your urge increases. So when you get out, what's the first thing you're going to want to do, right? They want to get right back to their drugs. I say, hey, you know what? There's this center over here at so-and-so location, and you can go over there and get care and whatever. Are you kidding me? It's like I have to ride 4 different buses to get there. So yeah, you're like, come on, ride a couple buses. This is your life. Get your life together. It's not that. He's like, if I ride those 2 or 3 buses, you know how many people are gonna offer me drugs on the way? And with that urge, you think he's going to be able to turn it down when he's just like at the height of his, his desire for his addiction? Yeah, there's a question.
So when someone's incarcerated for drug abuse, is there no any medical program in jail to taper them down off the drugs so that they don't have withdrawal symptoms or higher urges? So basically taper them down off the drugs so that they can get back to their normal routine without having any negative signs?
Yeah, so okay, so he's asking about drug treatment in jail, tapering people off, methadone programs, different substance abuse programs. So it varies completely from jail to jail. Every county can be different. Prisons can be different. Yes, there are detox cells. Yes, there are detox protocols. There's certain medications that we can give someone so that they don't go through the acute withdrawal. Because withdrawal, when they say kicking the habit, that saying comes from seizures and kicking, literally kicking. So yeah, it can be really bad, aside from some of the other, metabolic effects that can happen too. One problem is that substance abuse, going beyond that, doing substance abuse treatment, I'll get to that in a minute, so sorry, I won't talk that. But yeah, in answer to your question, there definitely is treatment for withdrawal, and it's one of the major things that we look for during intake. If somebody, especially if they're acutely intoxicated, then we know that 2 or 3 days down the line that they're going to be withdrawing from whatever it is they have. So every jail will have a withdrawal policy, and they'll have a procedure and medication. I won't digress, interrupt myself. So just to summarize about drug abuse, it's one of the major drivers for incarceration, as you guys could see. Worsens immune system function. A lot is transmitted by needle sharing, but by other things. So when they cook drugs and they use the water or the cotton balls or whatever, the spoons, anything, any of those things could possibly transmit infection from one person to another. Obviously, very high risk behaviors that are associated with them. They're marginalized from society, and when these people delay seeking care, when they have their little networks that they have, we have seen the evolution of new strains. So new strains that are resistant, new strains that just have molecular fingerprints, and maybe they're not any different. Like the TB strain that's in LA County among the homeless, it's not resistant to any drugs, but its genetic fingerprint that we can do genotyping now, it is different. We know that it's in this population and that it's not related to other cases outside of that population, for example. So that helps us understand the risk factors, how it's transmitted, and hopefully how we can prevent it. So really quickly, how bad is the problem? How big is it? And is there any solution to it? This is probably kind of small, but that's why I put the bullets on the bottom. 50% of jail inmates were high when arrested. So maybe they weren't high when they got to jail, because maybe they go to Irvine PD, maybe has, let's say for example, has a holding area where they stay for a day or 2 or 3. And then by the time they get to the jail, you look at him, it's like, this guy's like normal and functioning and talking to me. That's not what he looked like when he was arrested. And more than 2/3 were regular users. So that's one of the main things to take away from that. And when you look at this table, access to health, mental health, and substance abuse treatment in correction. So how many places do offer it? So 55% offer at least one. So that could mean we have a class. That doesn't mean we have methadone, or there's a medication that's an injectable medication for heroin users, for example, and it lasts for 30 days. So imagine if you're a person who's going to take an inhibitor, a drug called naloxone, and you take that orally. It's been around since like the 60s. And you get up in the morning, you're like, should I take the drug that's the naloxone? Now, if I want to get a high off of heroin, I can't get it? No, you know what? Oh no, I want to take that heroin. If anyone's heard someone who's a heroin addict, they'll say, there is nothing that compares to it. One time, they were hooked. It's like the best, highest, whatever thing that they have ever felt. And so by giving someone an injection now, they have it in their system for 30 days. If they take heroin after that, they don't get that high. So that, for example, that in addition to counseling, support groups, that could be effective, treatment. Keeping that person from going back into their same environment. They go right back into their same environment, they see all their buddies. Are they going to be able to say, you know what, you guys use it? I'm not going to use it. I'm just going to say no, right? There's no way. That's not realistic. So to say that, first of all, it's about a little over half to offer any drug abuse service. But again, that's not a comprehensive program. They could be offering, they could say, well, we have posters. They're educational. We have a 10-minute video. So that doesn't really mean that there's actual treatment. And 5 to 10% of the inmates incarcerated in the U.S. have access to these programs. So even if they do have them, we have a huge, discrepancy between users and the treatment that we have for them. So I'll get to some of the costs in a second. So basically, they have, they're eligible for it, but we don't give it to them. In jails and we still have some drugs in jails and prisons. I put Pruno up there. You can Google it if you want to find out how to make it. Don't make it. But just out of curiosity. Pruno is jail or prison-made alcohol. Starburst, toast, fruit in a bag, tied, a plastic bag, and they rot it together. So it's rotten. Why would you want to take it, rotten? But they can make this stuff. And Anheuser-Busch measured the alcohol content at our jail of one of these confiscated bags, and it was like 7%. So, it just makes, when I hear that, the first time when I heard that, it made my mind go in like a million different directions. So first of all, you're eating rotten fruit. And the first thing I'm thinking of, because I'm a geek, I'm thinking of botulism. I'm not thinking about getting a high. This can kill you. It's rotten fruit. There's a reason why we don't eat rotten fruit. But I'm also thinking like, wow, so with their own body heat and 24 to 48 hours of incubating this stuff, these guys are able to make, jail hooch or whatever they call it. It's called Pruno. You could do so many things if you're that intelligent. It blew my mind the first time I heard that. But also, I always like to say that it's a missed opportunity, because the first time that we thought about substance abuse treatment, and the first time I reported some of these things to some of these different treatment modalities to some of the sworn personnel, the really high up guys, and I was like, if these guys didn't do drugs, you couldn't arrest them. And they're like, oh. What more effective way is there to reduce reincarceration and recidivism and to take away that crime at its root? Big issue is on release. So I've been off of drugs for a while. I go back, I'm going to take my same amount, right? Because I'm going to take whatever the dollar amount that they measure these things in, or the same dose. Well, I say dosage, but you know, the drug abusers don't call it a dose, right? But now their body isn't going to react the same way. So in the first 2 weeks after incarceration, there's a huge increase in the amount of mortality and overdose after you get released from, especially from prison, but also from jail. Addiction's really high. They go back, and boom, we have, and then again, we pay for that, because when they go to the ER, who pays for that? That's us. So all of these different reasons are risk factors for them going back to using their drugs. When you look at housing restrictions and going back to social networks, their old friends, and employment restrictions. Some are formal, so some are certain jobs you can't have. You have any kind of record, that's it, you can't have that job. And some are informal. If they do a background check, or if you're honest and you put on there, yeah, I've been incarcerated, most jobs you can kiss them goodbye. So what are the treatment implications? Hopefully you guys, you're thinking about med school and getting your PhDs and stuff, and you're like, yeah, I want to do something about substance abuse. A ton of medical targets, so like medications, recognizing it as a medical condition. I know you're thinking, wow, they made that choice to go on the drugs. Let's put the root causes aside. But once they have that addiction, there is an axis between the drug and the neurobiology. They're not going to be able to get off of it. We have to accept the reality of the situation. Realizing that it's a chronic condition, that it's not going to be, we're not going to resolve this in a week or two. This is going to be years. Are there going to be relapses? Heck yeah, there are going to be relapses. I see patients all the time. Like, where were you the last 3 months? Was it crack or was it the meth? I know. I'm like, it's got to be one of those. Well, my mom died and then I couldn't take it and I went back to the crack. That's like their crutch, their old friend. Sometimes, I'm giving examples. It's not data. These are clearly, obviously, these are anecdotes, right? I'm not saying this is everyone. Mental health treatment also. These are all the different opportunities. I'm just trying to give you the opportunities. I don't want to bore you guys or belabor everything, but what I want to do actually is the opposite, is for you to look at this and go, you know what? There's this huge opportunity for a bunch of different things. If I'm interested as a provider, if I'm interested in some of the research, I hope that you go out and you're thinking about these types of things. Different models. So you could think about, instead of thinking about, well, I'm going to incarcerate the bad guys, you could think, well, you know what? I got all these substance abusers, and now what can I do to treat them while they're in jail, right? It actually costs, in California, it costs somewhere between $30,000 and $40,000 to incarcerate a person in the state. Because you got to do laundry, you got to have the guards, the deputies or the guards to keep them behind there, all these different things. There's no doubt whatsoever that if you put that same money into drug abuse treatment, that it is cost saving. It would save you money, and it would save us money as a society. And then re-entry programs for transition. These people have to get their lives back in order to get, when they get back out of jail or prison. So these are just some of the different behavioral models for anyone who's in social sciences. Very effective in addition to the medications. And there are a lot of different things, and there's not one type that'll work for everyone. There are different programs, and I hear that from people. They tell me, yeah, I went to this program, it didn't work. I went to this other one, and they had da-da-da-da, and that's what really worked for me.
I would imagine that these are all very difficult to implement within the prison.
Yeah, or our jail, yeah.
But are there opportunities to even try them?
Yeah, so access. So he's saying, it's really hard. Yeah, definitely. It's challenging. And that's why I talked a little about the sheriff's department and the custody and, the challenges of security. Whenever we bring anyone in to do work, it's thought, well, could this person be bringing in drugs? Could they be, what's going on? And that's their job. That's what the sworn guys do, and they do a pretty good job of it. But are there tremendous opportunities for community-based organizations. We have some that do some awesome work. Yeah, it takes a while. It's very challenging because the funding is soft money, a lot of it. So yeah, it's extremely hard. And what I'd like to argue is that we should make that a little bit easier. You know, there should be ways that we can make it easier. And if we were really progressive, we could find ways to offer this treatment without putting a lot of these people behind bars. I'm not telling you I'm the expert and I know the laws of how to do it. I'm not saying that. I mean, it's easy for me to stand in this here and say, well, yeah, we should be more. And I'm not saying I know exactly how to do it. But I'm just trying to get the conversation started for us to think about it. A lot of these incarceration-based treatment programs, the inmates are at least 1.5 times more likely to reduce coming back. And we've seen it in our own jail too. Some of these programs, we know that if they have community-based treatment, they're 7 times more likely to be drug-free and 3 times less likely to be arrested. So definitely, if it costs $26,000 per inmate per year, we know that's cheaper than $36,000 to $40,000 per inmate per year in California. And I know I got to get done because we had a lot of great questions. So, you know, but I want to respect your time also. So we know it's cost effective. Drug courts, for example, is some really good data. $1 spent on drug treatment saves $4 in incarceration and healthcare costs. So why don't we do it? A lot of the reasons that she brought up really early on. The economic reasons, the politics, a lot of these things. Are a lot of our decisions data driven? No. A lot of our decisions in this country are politically driven. You know, right or, well, I would argue wrong, but you know. There are a lot of challenges. I'm not going to go into the details, but definitely there are a lot of challenges as we were discussing. And for me, what I argue is, you know, so I do research technically, quote unquote research in the jail. I don't do research on new medications. I do research on, I want to find ways, how do we catch people? How do we get them into care? How do we keep them into care, you know? And that's a whole other discussion, because when you think of research in correctional populations, what are some of the things you think of? Anybody hear of Tuskegee? Right? I mean, so there's a big problem there with, you know, inmates were used as guinea pigs in the past, and that's by our government. So it's very challenging, but the opportunity here to do a lot of good for people, you know, you guys are going into a lot of you are going into professional fields to help people, right? And there's a huge need for this population and for you guys. I'm Egyptian, so I have to have a pyramid in my presentations. Sorry, bad joke, but I have to be honest about public health, academic institutions, the sheriff's departments, community-based organizations, that's what the CBOs are. Anything that we get done, you could put, well, we do a lot of HIV work with USC, but I put UCLA there. But, I mean, we do a lot with UCLA and with USC. Without this partnership, there are a ton of different programs that could never be done. So, is it the jail can offer this better alone? No. It has to be our condom distribution program, for example. That's a community-based organization that distributes them, not the sheriff's department. The sheriff's department just kind of says, okay, you can do that. We know that it's important. We've had syphilis outbreaks in the past, so you guys can use those. But without that kind of team approach, there's no way that it'll happen. It's just some acknowledgement. We're right on time. Even though you guys had awesome questions, and I skipped through a lot of the slides, I would much rather do that and have a discussion where half of you don't fall asleep. And you know, we discuss things that you're interested in. So thank you very much for your attention. Do we have time for more questions, or should I just hang around and if there? Oh, we do. Okay, there you go. So there's even more time for questions. Yeah.
You know how you said that you guys go in jail, you provide like better quality of healthcare? Do you think that's one of the reasons why they keep coming back to jail? Maybe like when they get out, they commit a crime because, I don't know, they have a condition, so they're like, I have to get treated, I'm going to go back to jail.
Yeah, it's true. Some people do. We know that. My gut is that it's not most of them. Most of them are coming back because they violated their parole, because they've they've committed another crime. They've been caught with possessing a substance or something. But yeah, definitely some do. And I've had patients tell me that. I've had patients tell me in the clinic on the outside, and I've had them tell me in jail. Like, yeah, I came back because I'm just tired of it. Like, I had a patient this morning who was just like, if I can't get into housing, I'm going to kill myself. I'm going to jump in front of a bus because I am tired of living this way on the street and getting drunk and being high and doing this, and I can't take it anymore. So he did get rearrested, that individual, on purpose one time. He asked the cops and they were like, no. And then so he committed a minor crime that violated his probation, but it was enough to land him back in jail. I don't think it's a majority, but it definitely does happen. And I don't know exactly how much it is.
Can I follow up on that?
Yeah.
Know there's another question. So I have been following half-heartedly the news about California healthcare in the prison and the federal role. I think for some time there was a receivership.
Yes.
And I don't understand any of that. I
Okay.
wonder if you want to, because if it's really good.
Yeah. No, that's a good question. Fair question. So he's asking about, okay, so I'll do the 101 kind of version. And I don't work in the state prison either. So, I can't give the really detailed description. But basically, partially because of overcrowding. So they estimated that 1 inmate a week was dying in the state prison system in California. Okay? So federal judge called a receiver. There was a federal judge appointed a receiver. And this receiver had authority to do whatever to provide good prison health care. So this receiver took over. It was no longer the state of California. So Jerry Brown wasn't in charge of the state prison anymore. Or, well, Schwarzenegger. But the receiver took over and said, we're going to set salaries for medical professionals at this level. Because one of the things they found is, well, some of these guys, they don't have licenses to practice. So we're gonna give high salaries to attract good, well-trained graduates. And they started doing a lot of systemic changes as well. And then they got to the point where they said, you know what, there's still some problems. And they realized part of that was just overcrowding. There's just way too many people for a number of different reasons that compromised their health care and their medical care. Is it the best? Is it? No, I'm not saying that it's like the best care. But actually now, when we decide whether or not we're going to implement a policy, so one challenge for us now at the local level, we have, for example, inmates that are usually there for 10 to 20 days, 30, 40 days. And now there's a law, you guys should know about this, called AB 109, Assembly Bill 109, that said non-violent, non-serious, and non-sex offenders are going to serve their sentences. There would be a felony conviction. They're going to serve it in county jails. They're not going to serve it in state prison because it's a little bit cheaper to incarcerate someone in the county jail, and it shifts the costs from our state budget to the counties. So now, when these guys were coming, I was like, hey, wait a second. You know what? I'm a preventive medicine doctor. We got to start thinking about mammograms and colon cancer screenings. We didn't think about this if we had a guy for a month or two, but now we have someone for years. So we have to think about chronic diseases, preventive screenings, and things we didn't used to think about before. So in that respect, and when we're going through the process, we looked at what's the community standard of care. So when we look at the waiting time for someone who's waiting to see the doctor as an outpatient, so to speak, in the jail, we compare that to community benchmarks. And that's how we determine and we argue that we need more funding to hire this many doctors so that the wait time is similar as if you're in the community. But we still have a lot to improve. There's no doubt about that. I'm not trying to brag and say that, oh, we're so great or something. No. But, I mean, the correctional physician that you see now is completely, a lot of my colleagues, it's like completely different than what you used to see, even 10 or 15 years ago. And I actually, what I do in the jail, I don't run clinics in the jail. I do the public health. I do disease screening. I do research. I do outbreak investigations. I don't have a regular HIV line or primary care line in the jail. I don't see patients in the jail unless it's part of an outbreak or, something else like that. So I'm not bragging about myself. I'm talking about some of my colleagues that I've been impressed by their standard. Sorry, other questions? I went really long on that one. Sorry.
Question back.
Yeah, thank you so much, Doctor,
You're welcome.
for your work as well as the talk. Doctor, my question is about, I guess it's just a personal question, that what motivates you to work with such a population, and how do you get through some of the more discouraging moments? And what advice would you have for us who want to pursue, working to eliminate disparities?
What motivates me is, I guess a few different things. And this is just, again, this is me, it's my personal motivation, is seeing the tremendous opportunities. When you see how many different opportunities you have to impact the population. It's endless. Just on a strictly compassion level, you see the opportunities, and there's so many things without even doing any studies or anything to evaluate it. You just say like, wow, there's so many. That idealist in you, don't lose it. Don't let people get you jaded when you get out, because it will. Life is hard, and there are people. Don't lose that. It's going to get hard, but that doesn't mean that you can't try and accomplish the principles that you're sitting in these seats for now, and that you're applying to, school for the next, what seems like 10 years, and training and everything. It's worth it. And when you deal with an individual, or when you deal with a population, and you get to see the benefits of what you're doing in the numbers, and you realize that those numbers are people, that it's not just data points. I always say that. The frustrations, yeah. There were times for sure where I was, one guy, he's a deputy, who started we have some gay and transgender dorms. It's one of the few jails in the country where people self-identify as gay or transgender, and they're put into separate dorms. I mentioned it, that's where we have the condom distribution. And that guy saw me, and he was like, "What's wrong, Mark?" Well, he could see it in my face, like maybe a year into the job. And I was like, he was like, yeah, I can see it in your face. And he said, you know what? If some of the people who are opposing you, if you leave, if you go somewhere else, then they won, those people opposing you, and your patients, the inmates, they're the ones who have lost. Like putting it in real terms and thinking about the people I supervise and mentoring them and helping them and the patients. When you put it into the human terms, it really helps you to realize, yeah, I can see what I'm doing. It's hard in public health, because in public health you may not see that impact every day. Or you may do something today and you may not see that impact for another year. So you have to, in your mind, connect those abstract kind of long-term goals to real people that you see in front of you. And I would say the human connection is huge. Like when I go to clinic and I have a couple good interactions with people, that helps motivate me sometimes for like weeks. Vacations, some of the practical stuff. And just to be honest with you guys too, my personal faith too. There's a verse from the Bible that I think of every single day I go to work. So, whatever your faith is, if that's something that, that's important to you. That's one of the things that keeps me from going crazy, actually, to be honest with you. Yeah, question?
When you said that meth is the number one risk for acquiring HIV, how is that risk assessed and calculated?
So, very good question. So, it's really tricky when you measure risk factors, and basically a lot of people, to give you a simple answer, they take data based on survey questionnaires. And this is why, if anybody's involved with a survey questionnaire, or if you are, and you see how researchers get extremely emotional about like research questionnaires, like survey, they're like, okay, it's just a question. But they get really passionate about it because that data feeds into models, like that data that I was saying. So they get risk-based surveys, and the way that they sample the population gives you an estimate of, you get a sample that gives you an estimate of the population, so you can make conclusions. Is it 100%? No, they're still there. It's basically models. So a lot of this, there's a little bit of hand waving. There's a plus or minus. So it's basically statistical models that are based on survey questionnaires and other data. So you can't know for sure. A lot of times, and that's a big question with substance abuse, and if is a disease transmitted by the substance abuse, or is it transmitted sexually? Well, that same network, they're engaging in all those same practices. In some cases, like hepatitis C, there seems to be some other transmission that's going on that we don't even know about. So household contacts may be more likely, to get hepatitis C. And it's like, no, they're not having sex, they're not sharing needles. So obviously there's something else. So really, we're just making our best guesses using as much data as possible. Some are probably, better guesses than others. Any other questions? You guys are still awake, at least that's good. Yeah. So, yeah.
How would you treat when you come in for
Okay, so I only work with the jail population, so it's adults, 18 or over. So we don't have any juveniles, but there are juvenile detention centers for people that are under 18. And how do you work with them? I've done like quality inspections. I'm with a group called a couple different groups. But basically what we do is we inspect other jails and we give advice in a nice way. It's not like a regulatory body. And we give them advice on how to improve their practices. And I learn a lot from them too. It's not just a one-way street. But when we've gone to juvenile facilities, what I've heard and what I've learned is that some of their care is more complicated because they have to get parental consents for certain things. And sometimes that parent or legal guardian is really hard to find. Because remember when I was telling you that it's like if your parent was incarcerated, you're 6 to 7 times more likely to be incarcerated. So a lot of times it's like, well, where's that parent? They're leaving an unstable life too, so they can't be found. But that's really where a lot of the opportunity comes. When you look at the numbers of like transmission of certain STDs and when people start using drugs, that's the time where you could really make impact and stop people from getting into the cycle in the first place. Any other questions? Yeah.
I was just wondering, okay, so like I understand that you care more, like you work on the public health side, and I was wondering, like, does having like your degree, like as a doctor, like how does that help you in the public health perspective, and like how does that, you think, like give you a different perspective versus people who just are like just with a public health degree? Like how much does that impact your view?
Well, that's hard to answer because I don't have I think of that in like research terms, like I'm thinking of a control, someone who's a Ph.D. who, and that doesn't exist, in at least like not in my, but I think the difference, for better or worse, sometimes when there are committees, when there are, a lot happens based on personal relationships. So when I go to some of the higher ups, and I have conversations, hey, you know what, my so-and-so had this medical problem, and they start asking me questions. It's just, there's some instant credibility that's built there. So in one sense, when I offer advice now as a public health practitioner, they're thinking doctor. Not that a PhD is not a doctor, obviously you're a doctor, but they're thinking of the doctor, and now I can give different recommendations, and I feel like that does have an impact, in that respect. And sometimes there are committees that have to do with Department of Health Services or Department of Public Health in LA County. And sometimes it's just, I have more credibility when I go to one of those places. Someone says, hey, can you be on our board or can you help with this? And I'm like, I don't know anything about your organization or your mission. At one point, I know a little bit about substance abuse, but like some substance abuse organizations say, hey, can you come to this meeting and help us advocate for blah, blah, blah. I'm like, I'm like a warm body almost. I know nothing compared to you guys. And they'll have me come because I'll add credibility to their cause. And I don't think that's exclusive to an MD though, necessarily. But for some people, it does seem to help. And I think me personally, I think it helps because I'll tell you how I do it, how I know that it helps is when I see patients and I evaluate them and I look at signs and symptoms, I make more practical policy recommendations based on that. Because I don't have data to know is if I look for a TB patient, or I was looking at a meningitis protocol the other day, and I know that there's data that tell me, you always say like neck rigidity is this big sign that people look for meningitis, and I'm like, no, it's not. It's not very sensitive or specific, but I know certain clinical criteria that I see in our population and how they communicate. And so I was able to put that in our policy. Some things that other doctors were like, huh? Or couple other MPHs that I was working with, they were like, no, what are you talking about? I'm like, no, I talked to the patients and this is how they communicate it. This is how, like, terminology and things that they use, that they're describing things that, and we found a couple patients that have had meningitis and they didn't die, basically. Their disease didn't progress because we caught it early. Sorry, really vague answer, but it's difficult, very difficult to answer. Any other questions? I think that's time. Thanks, you guys. Thanks a lot for your interest. Thank you. Do I get a UCI t-shirt?
Thank you once again for the lecture, Dr. Malek, and a token of our appreciation is a card and a t-shirt.
Sweet. Is it a UCI t-shirt?
It's a diversity in medicine t-shirt.
Okay, cool. Oh yeah, I saw them. Those are good t-shirts. Thank you, you guys. Thank you very much.